maybe we should just get started. There's a whole bunch of people coming in. I don't know if we wait for a minute or so. We had just asked, as you might see in the chat box, that so that we kind of get a sense of who's quote unquote in the room. Please put your name, and you can put your pronouns, where you're from, either whether it's an institution, or ideally it would be nice to know which country if you're not from the United States, where the conference is supposedly taking place, if it wasn't virtual. So let's get started. My name is Björk Paksutich, and thank you so much for taking the time to be with us today and contribute to this really important discussion. I know we've got participants from around the world, and I'm really excited that we'll be able to bring a truly global perspective and see this issue from its many manifestations, and to understand and at least begin the discussion around the bias, discrimination, and racism, both in health, workforce, education, and global health. Now, obviously, a huge, complex project, so this will only scratch the surface. I do want to quickly apologize to folks, because there was a blunder in the timing at some point where I was actually traveling, so the meeting on Eventbrite was put to a different time zone. So I apologize for those who initially logged on this morning and then discovered that it was later on. Now, I do want to start by thanking my co-conspirators here. This was really, we've taken the time from the really busy schedule to come up and co-create what we all feel is a really important discussion. These are people from around the world who are committed to social justice and have been working in their region, and some of them globally as well, to fight for social justice everywhere. Now, I can't say, I want to especially call out Dr. Sarita Verma, the Dean of Northern Ontario School of Medicine. It was actually a discussion between the two of us that got this whole thing started. And Northern Ontario School of Medicine has been kind enough to sponsor this session. So thank you for that. We really appreciate it. Now, other co-conspirators and participant in this is Toyoshe Oyeyeme, who's the Executive Director of the Beyond Flexible Alliance. We've got Dr. Eva Moya, who is Professor of Social Work at the University of Texas in El Paso, which is smack on the border, US-Mexican border. We have Dr. Vuleta Lema, who's the CEO and founder of Lalibela Global, which is both based in the USA and I think globally, as well as in Ethiopia. And we've got Dr. Walter Flores, who are you joining us from Washington, or are you joining us from Guatemala? I'm not quite sure, but he's the director of the Center for the Study of Equity and Governance in Health Systems in Guatemala. We've got Patanjali de la Roja. She's a chapter representative for Equal Health, their campaign against racism. And we've got student panelists, fourth-year medical student Anita Reta from the University of New Mexico, and senior medical student Hiba Makoub from Sudan, and Titsetio, and I can't do the clicking sound, from South Africa. You'll have to forgive me. Yeah, I'll need more preparation for that. We've also got a lot of help through the Network Towards Unity for Health from Senkiri Efran Kumi, who is a pediatric nurse who's from Ghana, but I believe is now in the UK. We've got a third-year medical student from India, Gladson Bagela. Dr. Amy Clitheroe, who unfortunately couldn't be here, she was also helping out. She's a faculty member at UNM. And then Suwexa Shah, who is a medical student from Kathmandu in Nepal. I know the session isn't going to cover, like I said, just scratch the surface. However, we hope that it will raise awareness of the many ways that conscious and unconscious bias and racism and discrimination, how that affects both the learners, faculty, and the communities that graduate health workers and learners serve. And we hope you'll be inspired and challenged to think about what's happening where you are working or learning or providing service. And we want this to be sort of a catalyst for inciting action. We know there's a lot of things going on at the moment in the world, and a lot of to draw attention from this important issue. So let's get started. I want to start with Dr. Sarita Verma. So I'm going to share my screen. If I can find how that works out now. Oops.
While you do that, if people want to see me, good morning, good afternoon, good evening. Love all these amazing international events where we're actually traversing the entire world. And I am incredibly honored to be here because the Northern Ontario School of Medicine is, you know, north of Canada. The snow is melting, but it is a very exciting, beautiful part of the world. And I'm so honored to be the dean at this medical school. So I wanted to set the stage for you with regards to this conversation. And I want to encourage you to say as much as you can in the chat, and then we'll be having breakout sessions in which, of course, we will be scribing the breakout sessions. And of course, we won't be ascribing anything to you personally, but we're hoping that today we will gather important information about something that we're all sharing, which is the impact of racism. The impact of racism in all of our communities and our environments, our countries, our medical schools, and something that has been the dirty little secret that people have never dealt with because there's so much undue influence in medicine and in many parts of our world. I'm excited to see 75 people here. I mean, when we talked about this, you know, and it's even growing now as I speak. I do have a conflict of interest, which is that I am an ardent anti-racist. And so anything about racism makes me extremely agitated. And so that is sort of a potential impact on the emotionality of my opinions. The other next slide I just want to show, Bjorg, is what we believe is the appropriate way to open all conversations in Canada, which is the territory acknowledgement of the entirety of our school and in the country on the campus of on the homelands of First Nations and Métis people. Even though I speak specifically about our universities, basically all of Canada belongs to the original people who are Indigenous in Canada. Next slide. So one thing that you can see is that our hope is today that we will learn and teach each other about health professionals and education institutions that perpetuate biases and discrimination, and the gaps that we need to do to prepare healthcare professionals to meet the needs of the most marginalized. And we will talk about key areas for research and action at the local and the global level, or as like I quite like to call it, the glocal level. Next slide. So you might believe that in Canada, everything is wonderful and that, you know, what a wonderful country. It's made up of settlers, immigrants, refugees, but there is a legacy of racism in Canada. Next slide. And I'm going to speak specifically about the stereotyping of Indigenous people, which is common and widespread in the healthcare system. Indigenous patients experience widespread racist stereotyping that has evolved from colonial beliefs. Next slide. So the Indigenous people in Canada experience harm and poor quality of care and even death as a result of the way that they're treated in our healthcare system. Next slide. In fact, we have good studies in the last 2 or 3 months that show that profiling and discrimination create mistrust and avoidance of the healthcare system by Indigenous people. And in fact, racism, prejudice, and discrimination in all settings are associated with lower health and well-being. Next slide. One of the cases in point that came up was, in fact, Justice for Joyce. Joyce Escoban was a woman who passed away in a hospital in the province of Quebec. And as she was dying, she was streaming on Facebook the racist comments and the pain that she was experiencing. And in BC, we've invested, you could go ahead, Bjork, to the next slide. Joyce's situation was horrible, but then studies in BC showed that 84% of the Indigenous people in British Columbia, which is a province in Canada, describe personal experiences of racism and discrimination. This is just in the last few months. This is not years ago. This is now. Next slide. In fact, even close to home in us, in Thunder Bay, 2 events happened that have really affected me. Barbara Kentner was walking down the street innocently in Thunder Bay, and a man in a pickup truck drove by and threw a trailer hitch at her, and she died as a result. The controversy around the trial and his attempts to get out of anything to do with her death, which he caused, as well as the way that the media actually talked more about her mental illness and underlying diseases to justify her death, was completely unacceptable. And the next slide, please. And of course, not too far ago, almost 6 months ago, a young 19-year-old Face Nations man went to the hospital and said he was suicidal, was thought to be inebriated, and so was escorted off the hospital premises, and he committed suicide and was found dead, hanging the next morning. This was just last year. So next slide. These events are not unusual, and our First Nations people tell us that they experience overdose events or deaths and are more likely now to contract COVID-19. Next slide. And this is not new. In fact, Brian Sinclair died a few years ago as a result of being thought to being inebriated when in fact he was suffering from an underlying chronic disease, and he died in the emergency room. And in fact, these are my key messages. Disability is not a risk factor, but ableism is. Race is not a risk factor, but racism is. Gender is not a risk factor, but sexism is. And indigeneity in Canada is not a risk factor, but colonialism, Christianity, and the impact of Christianity and capitalism are. So the next slide. So at NASM, we have made a commitment to social accountability. And this is the same definition that has been adopted by the WHO. So next slide. And as part of our social accountability, we are going to reset our curriculum, our policies, our admissions, using engagement, decolonialization, advocacy, equity, and anti-racist approach. And we are creating a culture of respect, kindness, and wellness. Next slide. So for us, the movement is through NASM about social awareness, and this is one example by being part of this event and speaking up. And the next slide. And we call that the NASM Challenge. That's our new strategic plan. Next slide. And part of our this year is devoted to climate change and social justice, activism, advocacy, and agency. Next slide. And so today I want to introduce the topic, bias, discrimination, and racism in health, workforce, education, healthcare, and global health. And as Bjorg has introduced our key planning group, we're pleased to go forward, and I'm pleased to have set the tone, I hope, which is that there are issues. There are issues everywhere. Canada is not exempted from these issues. And in Canada, we are working closely to address the particular issues of Indigenous racism against Indigenous people, but all forms of issues of equity and diversity. Thank you so much, Bjorg, for running the slides. Folks, we're now moving into the main part of the workshop, and keep thinking, keep writing in the chat, and we'll be looking forward to the breakout rooms. Thank you, Bjorg.
So the next speaker is going to be Dr. Lionel Green Thompson. Let's see if we can make this. Struggling a little bit with sharing my screen here. Let's see, hopefully it is coming. So I will then hand over to you, Lionel. Let me know if you've got trouble seeing it. Does everybody see it? You just tell me when to move.
Thank you. That's fine. Thank you very much, Bjorg, and thank you very much for getting this group together. I think the conversations in preparation for today have been incredible. As we would say in these parts, molweni, to all of you in all the different parts of the world that you're joining this conversation from. The South African legacy is really rooted in a pre-colonial time, which was very communitarian in its outlook. Then there was a colonial time which has been characterized by violence and dispossession. And then in the last 25 years, we've entered a post-colonial period in an attempt to reconstruct our society into a kind of society that allows everybody to reach their full potential. But the reality is that even as we journey from bias to Ubuntu, there remain significant barriers to that. And one of the barriers is that, in fact, many of our views of the world have not been reconstructed. So in the next slide, I really want to speak a little bit about these three dimensions. Bias, and that is the root and has originated deeply from the South Africans' concept of apartheid, a society which was based on separation. So the biases that we inherited from that period continue to linger in the system. The second is this idea of asymmetry. And one sees that asymmetry played out in many of the relationships between white-held and white-controlled areas, some of which are very significant in our society still. But they also they also manifest themselves in the asymmetries between the urban and the rural, the doctor and the rehabilitation specialist. All of these are asymmetries that we've inherited from our past. But I suppose particularly important is this hierarchy. The concept of a hierarchy which continues to ensure that a certain group of people is held at the bottom of that hierarchy. Many of these things are inherently still race-based in South Africa, and many would say that in our society, being Black is still a proxy for being poor and marginalized. So colleagues, in the next graphic, in the next slide, I just want us to talk a little bit about this idea of Ubuntu. Because if you stay in the darker blue frame outside, what Ubuntu begins to call us to is a different construction of society. And for me, it is the ideal construction of the ideal look at social accountability and how it should be manifesting itself in our relations. You'll see that at the bottom, the tension between vulnerability of marginalized groups and the power and empowerment of privileged groups, often in South Africa still determined by race. And for me, Ubuntu comes into that space between to help us reconstruct those relationships. But what it does expect of us is each of us who come into a privileged situation, and I myself am even though I'm what South Africans would call a colored person in America, I think they call them mixed race people. The reality is that my class has often determined that I do enjoy a certain level of privilege. But as we move vulnerable communities into a place of rights, those of us who have privilege, and particularly in South Africa, we've got to acknowledge that shifting white power to a sense of responsibility, the capacity to build relationships that matter is really built. In the next slide, colleagues, what I want to argue is that, next slide, is that what we're asking here is that if we're going to build transformed Ubuntu-type relationships, then we need to move bias from a sense of bias into an acknowledgement of dignity. And all of the traditional notions where, for instance, in our society, very much a doctor still prevails in the team, we need to move towards the dignity of all people. And the asymmetry of relationships that I referred to earlier needs to move to a greater sense of equality. But it does mean that privileged groups such as white professionals have also got to recognize their role in shifting to a different place. And if we can move our hierarchies, which are very entrenched both in the health professions as well as in societies, if we move that towards the community of practice, where all of our engagement in that community of practice is legitimized and is also valued for the contribution that it brings, then I think we begin to move towards a society built on Ubuntu, this sense of African humanism, which calls us all to make a contribution in our society. And then in the last slide, I really want to just I really just want to say thank you. That's a picture of our university. That's a picture of our university, and that is how we say thank you in all of our languages. Ngiyathokoza, ngiyaleboga, nkomu. Thank you. Ngiyabonga, enkosi. Thank you very much, Bill.
Thank you, Lionel. Let me just, the next is actually, we're gonna have a video from Toyeshe Oyeyemi. So we'll find how we can open this and make this work. Apologies for my technical incompetence here. I'm trying to work on my husband's computer, which is a Mac. Let's see if this works out.
Hello, my name is Toyeshe Oyeyemi, and I'm pleased to be able to share a bit today of what I believe to be an instrumental and often overlooked asset in addressing institutional racism, particularly as it relates to institutions that train our health and healthcare workforce, and increasing health equity in particular. Just a quick bit about myself. I'm a public health practitioner by training and the director of the Beyond Flexner Alliance at the George Washington University in Washington, D.C., where I'm also a senior fellow for health equity, in addition to being a lecturer at the University of New Mexico in the Department of Family and Community Medicine and the College of Population Health. So I wanted to start by taking a step back and looking at a bit of the legacy that's led to where we are. In places like the United States, there's a long and clear history of academic institutions being driven by a legacy of structural racism. The infancy of many of these organizations involved overt policy that excluded entire communities of people. So for example, the 1910 Flexner Report was responsible for the closure of multiple medical schools across North America, including almost all of the Black-only schools that existed within, in the 20th century. This report also indicated that Black providers and trainees should only be allowed to practice on Black patients or serve as paraprofessional workers. This undoubtedly impacted the educational achievement gap, production of providers of color, and it ultimately impacted community health outcomes. This legacy of institutional exclusion. So the legacy of these policies has led to workforce outcomes that are rooted in racism. And now we see many academic institutions that have rightly taken it upon themselves to address the inequities within their systems. But the question then has to be asked, how can these schools that have been built on separation and exclusion now be trusted to or expected to properly correct their own actions? What level of accountability could or should we expect from those who are benefiting and are even in decision-making places of power as a result of these structural inequities? And even if you were to believe that an academic institution is sincere in their self-policing and self-accountability and social accountability, how are they able to address these issues without engaging those who have been the targets of their historic impact? This need for authentic engagement with communities, especially historically marginalized communities, becomes even more critical when you consider institutional racism regarding healthcare workforce specifically. And that's because the institution of education and the institution of healthcare have both been hyper-marginalizing. In the United States, there have been growing recent examples of anti-Asian discrimination towards patients and providers of Asian descent. There have been more high-profile examples of Black medical faculty and healthcare workers being unfairly treated by their schools and hospitals. What message is this sending to trainees? How is this speaking to the self-efficacy and self-confidence of students of color who want to become healthcare professionals? And if we're seeing this continued devaluing of Black people at the leadership level, what hope does that give us for valuing Black people at a broader community and patient level? There are examples of ways in which healthcare and health professions training programs and institutions have engaged community to address the structural inequities that they have perpetuated. One way in which this has been done is through institutional responsiveness to community. For instance, in New Mexico, they have implemented a model called health extension, where the strategic plan of the academic health center is being driven by the priorities that have been set by community. By having place-based agents, the institution is better able to partner with community organizations outside, far-reaching from the university, to address social determinants of health that is centered on community action as the resource. And the university is simply a supporting cast to supplement clinical resource, educational resource, research support, and human resource. Another example is community college partnerships as a pathway intervention to addressing structural racism. In the United States, community colleges are often more accessible institutions, especially in rural communities and frontier communities, and often in more inner urban neighborhoods. They reach a wider range of learners, from high school age students through programming like dual credit programs, to adult learners and residents seeking technical training. Engaging with more traditionally accessible partners like this makes us, in turn, more accessible to those who we're responsible for reaching. And one of the interesting dynamics of COVID-19 as it relates to community engagement is that responsiveness is only half of the bi-directional relationship that needs to exist. The second half, in fact, because that first part is listening. It's reflexive and reflective listening, which involves being in spaces where our communities work, live, and play. And technology has been one way of keeping us connected. Obviously, even this discussion is an example of that. But the unfortunate irony is that those who are most in need of being listened to have the poorest access to the social inclusion that technology platforms like this provide. So what occurs is institutional priorities become less guided by community informing, right? Unless there's already a well-established line of communication, unless there's already well-established avenues of trust and well-maintained relationships between institutions and the communities that we serve, so that we're able to continue to be responsive even when there's a limited amount of communication, even when there's a limited platform to be able to work across communities and across sectors. So the summary of what's important for community engagement as it relates to how institutions can address the structural racism question that lingers throughout all of these different scenarios is a couple of things. One is for us to assess who are the stakeholders? And who is it that's been historically excluded or harmed through our practices and through our policies? The second is to seek and to understand that there is tremendous value in intersectoral partnerships and to be creative in identifying where those partnerships may exist. And the third is to remember to center community engagement as an intervention for structural exclusion, and understanding that the act of authentic community engagement needs to be properly integrated across different core functions of an institution in order to be truly effective and not performative. And that is largely the responsibility of institutional leadership. It's important for community to be able to have greater access to the resources which we're able to pull together in abundance through universities and academic health centers. This is the way that we're able to draw on our community as an asset and be able to properly decentralize and distribute the resources that that are needed by those who have been historically excluded through racist policies. Thank you.
Thanks to Toya Shade. Let me just see how to get out of this again. Okay, so the next I will be, we're going to actually start with a video from Anita Reta, but afterwards, Dr. Lionel Green Thompson is actually going to facilitate a short panel discussion before we head out into breakout rooms. So let me start the video and see if I can get this going.
Hello, my name is Anita Reta. My pronouns are she, her, hers. I am a queer mestiza femme in my final year of medical school at the University of New Mexico School of Medicine in Albuquerque. Because of colonialism, many people of color have been forcefully separated from the traditions, medicines, and spiritualities that have kept our ancestors alive and thriving for generations. This is not a remote phenomenon. My mother, having been punished so often in school for speaking Spanish, began to resent the feel of those words in her mouth, so much so that she decided not to teach her children the language of our grandparents. Presently, forced assimilation continues as I've experienced on my academic journey, each step forward taking me further and further away from the communities I represent and wish to serve, and demanding more and more that I appear and act differently in the name of whitewashed professionalism. We call it imposter syndrome, this feeling that we don't belong. But we know that the U.S. healthcare and the U.S. education systems were not created equitably nor with us in mind, thus explaining our low visibility and presence in these spaces. Medical school was especially isolating at times. However, through the formation of our coalition, White Coats for Black and Indigenous Lives, formed in the wake of the murder of George Floyd, I have formed bonds with a network of clinicians, faculty, and learners across campus who share my passion for social justice and understand why we need to center our work on the needs of our most disenfranchised communities, Black and Indigenous peoples. Though it has been difficult and at times painful having to educate administration and demand meaningful change of our institution, the camaraderie has re-energized me and given me hope for medicine. It has reminded me how important it is that I continue to utilize my voice and privilege in pushing forward this important work.
Thanks to Anita. So I believe I'm handing over to Lionel. Can I hand over to you to do the discussion? Maybe, yeah.
Thanks very much, and thanks very much to Anita for starting an evocative part of this conversation. And I think we've called this section Courageous Conversations precisely because we're trying to hear different voices from across the spectrum. And so we're joined by 4 students or at different levels of undergrad and postgraduate studies who will each answer an initial question, and then we will get into a conversation with them. But the students are Patanjali de la Rocha from the United States, from Washington, Hiba Magub from Sudan, Anita Reta, as you heard earlier, from New Mexico, and Tiseto Tlaba from South Africa, here where I am as well. So I'm going to start with Patanjali and just ask the question that there's clearly a growing movement to recognizing racism as a public health crisis. If we begin to understand racism as a social determinant of equity, what are the challenges and concerns that emerge with thinking about it like that?
Yes, thank you for this and for having me here. Pialino Toka Patanjali, Mimi Huala Seattle, Nechpakti Mimi Tichmakli. My name is Patanjali de la Rocha. I'm calling to you all from occupied Duwamish territory, which is now known as Seattle, Washington. I identify as multiracial Indigenous. I want to thank you all for having me here and the other panelists. And as part of my work with the Equal Health Campaign Against Racism, we have currently undertaken a policy analysis on the declarations of racism as a public health crisis and looking at them through the necropolitics lens of pharmacon, of whether or not this is something that can be medicine, poison, or both, and the ways that that oftentimes social justice language or language rooted in communities of color becomes appropriated and then weaponized against those communities by larger institutions. And so I think I appreciate what has been shared so far in thinking of ways to thoughtfully partner and connect with community. And the way, you know, it also makes me think of the very recent JAMA, the Journal of America, for doctors, sorry, which I will post in the chat around saying no doctor is racist, so how can there be structural racism, right? Yeah. And I think that very much speaks to the way that racism shows up, and that itself is an example of the way that structural racism perpetuates. And I have experienced that with many professors. I really related with what Anita shared of needing to just challenge and bring awareness to the ways that, like, the curriculum, the readings, the way that communities are talked about as though they are not in the room, and that our voices and our values are not recognized as valid and often challenged. I've definitely been treated as though I am ignorant, a poor student, I don't understand things, I need special attention, simply for trying to bring in community-based values because there's no evidence behind them, right? So we have to think very carefully on every level. And I guess I recently had an interaction with a professional who leaned on her decades of experience within global health when I challenged her approach as potentially being harmful. And so I just want to share the same words here for particularly all the white professionals in this space to consider. So I deeply urge you to consider the ways that your approaches may be rooted in ableism, in exploitation, in white supremacy and violence. And to do that labor on your own. And if a community member or someone you're working with tells you something's problematic, do not seek out the opinion of another person of color to tell you that what you did is not wrong. And deeply, deeply sit with that, right? Particularly for white Westerners working in global health, like, you are profiting from the violence, the legacies of colonial violence of people in the global South. Like, your comfort, your wealth, everything comes from that. And to not be aware of your privilege and positionality as a white Westerner in that position from the global North is deeply disturbing, right? And I don't need to know you. Oh, am I done? Sorry.
No, thank you very much. I just want to make sure that the other colleagues are heard as well.
Thank you,
but thanks very much for that sharing. And we'll come back to some of the ideas that you've raised. Now, I'm going to ask the next question of Tiseto Tlaba. Tiseto comes from what you call a township in South Africa. But Tiseto, I wanted to ask, in your journey from that kind of environment, what are the barriers that you've experienced for access into universities and then your success in the university? What are those barriers that you've experienced? Tiseto, will you come online?
Thank you very much, Prof. Am I audible?
Yes, you are. Go ahead.
Okay, thank you. So in South Africa, of course, we have challenges that or barriers that actually prevent us from accessing higher institutions. And I think the main barriers that I have personally come across, first of all, of course, institutions of higher learning, they play a crucial and a major role in shaping, health professionals and our health systems. And also the institutions, they also orient curriculum processes and content towards the goal of producing competent professionals in all aspects of health and health systems. So with this in mind, institutions, administration, and organization, of course, of the curriculum, it is an important catalyst for innovation and change, in our health systems. The University of Cape Town specifically has committed to train health professionals with emphasis on primary health care. Now, this ensures that the professionals themselves follow the principles of primary health care in delivering their health services. And then this improves societies. Now, many barriers exist in accessing these institutions. The barriers in South Africa can be, differentiated into accessing the higher institutions, but also barriers in fully engaging in this higher institution, given that you've now accessed the institutions. Now, I don't want to undermine the importance of the university entrance requirements, such as the national benchmark test in South African universities. These would be similar to the standardized tests like the MCAT in the international arena. And also the medical reports that are required for those students who intend studying in the health sector. So these often have an exclusionary effect, which disadvantages students who are already marginalized by poverty and poor academic performance in under-resourced schools. And also, without failing to acknowledge interventions by government funding and other bursary schemes, the high tuition fees in higher institutions, of course, save where there is academic excellence, means only those with a high socioeconomic status are able to access and fully engage in these higher institutions. But there are, of course, other, predisposition factors which may cause students from poor background to be reluctant to apply at what they may refer to as top universities. The University of Cape Town is also one of those. This is due to a lack of motivation. I also used to ask myself whether I am fit enough to apply at such a well-respected international university. I always thought that it was way above my league and was not for people like myself who come from poor backgrounds. So another issue was the application fees at various institutions. They also serve as a barrier that needs to be overcome. So students intending to apply at more than one institution, so as to increase their chances of being admitted, we end up having to pay significant amounts of money. Unfortunately, this is not possible for many students, and we end up applying at only 2 institutions and risk getting rejected, but of course, hoping for the best. One last important barrier that I came across is once you are accepted into the institution, you have now to face other barriers and overcome them. What happens is you find manifestations of racism in the university. And a minor example would be many buildings in the universities and many statues still have the names of colonists, of those people who were privileged as a result of the apartheid history in South Africa. So it would be encouraging to have buildings or statues or even lecture halls bearing Zulu or Sotho names on campus in the University of Cape Town. And of course, there are many cross-cultural events which often lead to, nation building, but they are not celebrated enough on campus, and the university does not prioritize those in order to do away bit by bit with these manifestations of racism. So for an institution, the University of Cape Town, with so much diversity in terms of background, ethnicity, religion, gender, and many other ways diversity manifests itself, the University of Cape Town is still in its early stages towards reaching a safe and inclusive space in which all students can be safely accommodated. And so we have inherited a culture as students of being too reluctant to confront our own privileges in order to bring about transformation. Although the stats are improving, there is still a clear supermajority of white lecturers as compared to other ethnic groups in South African top universities, and a clear supermajority of white students in classes. And so you'll find that half of the class is white students, and then the other half has to be shared between Black students, coloreds, Indians, and other international students. And so this minimizes our way of fitting in. Thank you very much, Prof.
Thanks very much, Tisetso, for those experiences. I think from a journey from the outside into the center of the academic enterprise. I want to just ask Juanita Rieta, I just want to ask about your experience as a student and the ways in which you felt that white faculty could have better supported you and other students.
So, you know, a lot of what has already been said is the biggest things. I think I'm preaching to the choir a little bit. You know, if you came to this discussion, you already are showing that you are dedicated to anti-racism and you wanted to learn. And so when I think of the ways that white faculty could have supported me better, I think of, you know, doing just those things, approaching these discussions with humility, but also, as Patanjali mentioned, you know, doing this education yourself and not necessarily requiring people of color to have to explain their experiences to you in order for you to understand where they're coming from. You know, like, look at social media, follow people of color and leaders that are from communities and not just academics, you know, read memoirs. You know, another good book that I think of is So You Want to Talk About Race by Ijeoma Oluwa. And so looking into other ways to be aware of the social issues and the historical trauma that's going around you, and not feeling that it's a problem separate from you just because you're not directly affected by it. I think understanding, again, that there are experiences that are different from you, and that doesn't necessarily mean that they're wrong or negative, and being open to understanding that those perspectives are present in the classroom, are present in the hospital, and are present in the workforce. And, you know, students who have had to navigate white space the whole time that they've reached this level of education, we've become hyper aware. We see the tone in which you speak to your colleagues, in which you speak to low wage workers who are oftentimes our family or more accommodating to us than faculty are. And so we are a sponge, we are observing, and so it is very easy to figure out who is safe to speak to and who isn't. And so we really need a larger amount of faculty to stand up to their colleagues who are committing microaggressions, who are outrightly saying that racism doesn't exist, such as that JAMA article, and really just showing up and advocating, not just immediately when there's a problem in front of you, but demonstrating outwardly your dedication to these issues so that we can observe that and understand that you are allies.
I think you raise a really important point, Anita, about the tension of role modeling in this space. And perhaps what part of the challenge is that one needs to challenge colleagues at the same level to role model a different reality. Thank you very much for that, Anita. I'm going to ask Hiba Najee Magoob, who's a final medical student in the Sudan. She speaks to this idea of the fact that it's very easy in the world that we're in to develop anti-Muslim sentiment. And that's often a sentiment that's really the other side of racism. They're often a single experience happening together to the individual who may form part of both being a Muslim and a person of color at the same time. Hiba, I just wanted to ask you to share some of your experiences in your learning and in your journey through medicine, understanding how you've experienced those two things.
So, thank you, Dr. Lionel. And so, hello again, this is Hiba Mahjoub from Sudan, a final year medical student at the University of Jazeera. And so, in the basics of disparities towards the Muslims, and what makes this so conceptuous. And myself, I didn't experience racism based on a religious background, as being a Muslim and raised in a Muslim country, but I did experience racism based on the being a Black woman and being a foreign in a country. That's happened when I seek medical care in Saudi Arabia. So nevertheless, I believe that Muslims do face disparities when they seek medical care. Medical care, and I believe that long-standing suspicion of Muslim has been instigated by the decades of events worldwide in which the Muslims have been central. So they have been stereotyped, and especially as you all know that they have the event that may have touched all of us, and the sad events of the 11th of September. Sorry. So I believe this was the transformation point that left a deep scar, which didn't heal yet. So I believe that somehow made this anti-Muslim racism conspicuous. Regarding the anti-African, this is have a historical background, and you know that the roots of Blacks' mistreatment in medicine run deep from this segregated waiting rooms into the experimentation on African Americans patients without their permission, to believing that they do not suffer pain. And this is what is interesting, that I've been across some corners that reported that the painkillers that was prescribed to the Black people is the half amount that the same painkillers are prescribed to the ones who are white patients. So also there's sometimes they not believing on the patient issues, they also ignore them, and or maybe they downplaying them. And then there's the long-standing running healthcare system racism from the institutional until the healthcare provider. So it's a personally mediated racism. So this is also containing less touching, closed arm when you are examining the patient, and also keeping further from the bed. And so lastly, also this goes with racist patients who are being who are refusing to be examined or to be checked by a Black doctor. So as all have mentioned, this is a great topic to discuss, and it have a great impact on the medical practice. And everybody has to consider racism as a determinant of equity. So that's all I got to share. Thank you for the chance. Thank you.
Thank you very much, Hiba. So colleagues, we're not going to get to much of a discussion. So what I'm going to do is just starting with Hiba now and going back through the panelists. I'm going to ask you to tell us in one sentence, and I want to recognize the courage of the things that you've shared about today. So Hiba, let's start with you. If you said that, if you in one sentence, and I want you to keep it very short, what is the thing that you would change today in your context and in the world in relation to the thing that you were talking about? One thing that you would change immediately.
So, yes, thank you, Dr. Lionel, for the question. So, in my context, as I said, I've been raised and I've been now living in a Muslim country, so I don't face anti-Muslim racism, but we do have violence, and we do have disparities towards those from other races. So I would like to stand with them. I would like to, let people understand more about this. My colleagues in the university and in the college. So something just like promoting such sessions, promoting such topics, promoting such discussions will help a lot.
Okay, thank you very much for that.
What I can do in this level.
Okay, so what I'm hearing you saying is solidarity with victims of violence. I'm going to ask Anita again, in one sentence, Anita, if you can tell me the thing that you would change today. Very briefly in one sentence.
That I would change or that I would like to see?
Or that you would like to see. That's also fine, yeah.
Okay. I would like to see our white neighbors and especially administration with the highest privilege and resources to make a stand and be a very visible advocate for funding for diversity efforts, for demanding adequate compensation for those who engage in this work, and for being out in the community advocating for important things like deprivatization of prisons, reform of police, all of those issues that affect us outside of the healthcare sector. I would like to see more of our white faculty involved.
And again, it's about that privilege taking responsibility for the change they want to see. Thank you very much for that. I'm going to ask Lisetso. Again, I'm going to encourage colleagues to give only one sentence because I think we're running out of time. Lisetso, what would you change today in the context that you're in?
Thank you very much, Prof. I think what I would change is to, or what I would like to see is institutions of higher learning. They should not only adopt transformation policies, but find practical ways of implementing these transformation policies so that we actually see transformation on campus and it's not something that we just speak of as an abstract concept. Thank you.
Thank you very much. I think that's a very important contribution. And then I'm going to finish with Patanjali. What would you like to see? If you would be able to insert something today, what would you like to see?
Yes, thank you. I think so often we see narratives of violence experienced by communities of color as though this violence is just happening, you know, and without accountability for the ways that it is being systemically done. So I'd like to see more about talking about oppression in terms of the violence of those in power and also focusing narratives on those from historically oppressed communities, focusing on their resilience and their capability. And so we're really uplifting ourselves instead of seeing ourselves as victims.
Thank you very much for that. And I think that that's a really important thing because I think changing the relationship between victims and those who create victims, I suppose, is about this idea of the intersection of compassion, humility, and justice. So thank you very much, colleagues, for these courageous insertions you've had into this conversation. And I'm going to ask Bjorg to then take over the conversation from here. But I think we are due for a... No, not yet. Okay. So Bjorg,
for a health break?
Not yet.
Not yet. We're doing this a little ad hoc. The plan is to actually have a 30-minute breakout session to give people an opportunity because we know there's a lot of wisdom in this group that's attending. And then the idea was to have a sort of a health break after that discussion. So I will open the breakout rooms unless if there's a major call for actually giving people a health break before. That's also the option, but otherwise we can open the breakout rooms. There's actually 5 rooms with 4 topics. One is around what needs to change in terms of students' admission, who's learning, who are the learners, who are the health workers. And the second one is around the competencies that this requires and the curriculum that needs to change in order to address racism and discrimination. And this, I want to mention, this is not, even though racism is a huge part of this, there is discrimination on many levels. So all of them are on the table. And the third one is around institutional policies. What needs to happen, whether it's with decision-making, whether it's around promotion of faculty, recruitment of faculty, etc. What is it that institutions need to do, you know, bringing it to practice, if you will, in terms of the policies, but I think also the culture, what needs to change in the culture is really important. And then there's 2 sessions on community engagement. So please feel free to choose the rooms you're interested in. If there is a large group that goes into one topic, we might move you between rooms, but hopefully you'll be able to participate in a discussion that is of interest to you. So I'm going to open the rooms. Hello, everyone. I assume people are trickling back. Hope you had good sessions. I felt very lonely out there because I didn't know which session to go to. So hopefully I'll love to hear what happened in the session. So I'd like to ask, just when people are sort of trickling back in, maybe we can hear from THEnet, room 1, about the key thoughts that came out of that discussions. I know we were not doing the topic justice, but love to hear some key thoughts. THEnet, are you? Okay, not THEnet, so then should we try Suvexa? Is she there? Group 2? From competence?
No, I didn't see her. I think she was having some technical issues, but I went ahead and took some notes at the same time.
Oh, thank you so much, Anita. Could I hear from you what happened in your group?
So we were discussing curriculum and competencies around anti-racism and anti-discrimination. And, some of the issues that were brought up is currently, when we discuss these issues, it seems like these discussions are geared more towards white students and white learners. And so even though they may have the least experience with dealing with these issues, we need to understand that, folks who are actively going through these issues are also in the room, and also are learning the academic language to finally explain some of the issues that they're going through. And so where is that there's a tension between teaching with humility, but not re-traumatizing marginalized folks that are in the classroom. And then ideally getting experts from the community. We talked about the social accountability mandate from Danielle, and also about how in Canada, there are folks that are faculty that are brought in who are basically cultural experts, and they're available for faculty to come in and talk to and learn about these things, and also to help direct coursework. And so I think we discussed that it's very important to get folks from the community to go over this curriculum, even though we know that we have a shortage of faculty and learners who are from marginalized communities to directly teach these things. So we need to supplement that with community. And yeah, so those are the major things that we talked about. It's still so abstract, so we didn't come up with direct competencies, but we talked briefly about microaggressions, and not just how to respond to our colleagues, but also to how to respond to our patients who are being discriminatory, and to protect ourselves and learners. So
excellent. Yes, as I say, we're just scratching the surface, but hopefully this can be the beginning of a much broader effort to really look at this. And so thank you so much, Anita. THEnet, are you available for group 1? Or if not, maybe...
I don't know where he's gotten to. Can we give him one more round? Go to another group, please,
Sure.
Bjorg, and we'll try it again.
Absolutely. Absolutely. Lise, can I ask you to speak about institutional policies?
I'm going to do it because Lise was taking notes. So it's Sarita. We had a great group. I mean, in fact, we basically went through the whole group and we ran out of time because we wanted to go through everybody's perspective. So we had some fantastic examples of the struggles that institutions go through, from Dr. Bentley describing Rocky Vista University, and how the challenges in achieving diversity of students and diversity of faculty. We heard from Dr. Mozaffarian on how to go around dealing with the issues of unconscious behaviors rather than unconscious bias, which I really liked. The concept that, bias immediately gets people's back up. But when you talk about unconscious behaviors, you acknowledge the kinds of activities and you then actually address the role modeling that happens by faculty or by colleagues in those behaviors. We heard from Dr. Roberts about the Alliance for Visible Diversity and reimagining and decentralizing racial inequity so that creating multiple, I guess I would think, networks around serving different populations in the institution. So I thought that was really interesting because most people take a central institutional approach towards dealing with a issue policy. And this looked like a really interesting decentralized approach and a way to actually make community engagement more involved. We had Dr. Martin in our group and his commitment to improving education and advocating for policies that entrench poor outcomes for minority communities, and as well as a very interesting idea again from Dr. Mazafarian around policy change in student admissions, making their lived experiences one of the metrics for admissions. So, you know, from institutional systemic racism, policy, leadership, structures, and advocacy came forward as the four major approaches.
So leadership, I'm sorry, so leadership, structures, and advocacy. There was a fourth element, I'm sorry.
Leadership, structures, policies, and advocacy. So the policy being that you need to have a code of conduct or you need to have an anti-racism policy that you can actually, you know, use to enforce behavior. That's kind of disciplinary, and I don't think that's what I meant. But
Excellent. So if Tisetso is, I can't see if he's back.
I really don't know what's happened to him.
Okay, so
he had prepared a really good presentation to give.
okay, so we'll give him another chance, and we'll have him last.
I'll give him a call now because I see he's not here. So.
Sure. So Sankiri, you had one of the community engagement group, right? Could you give us a little?
Eva will present it. Eva.
Okay, Sinkiri, we had Christy, Katrina, Allison, Jolanda, Georgina, and Shokat. Our topic was about community engagement. And so we went from, well, what is it? And how does it work? And what are sort of like a little bit of the challenges? But most importantly, how do we honor the communities that we serve? So we were reminded that community engagement is grounded in community, in organizing in fairness, justice, empowerment, and participation. Some of the highlights include that really, in order for the engagement to be meaningful, community really needs to own the solutions. So we come as sometimes the foreigner, the stranger, the resource, and we need to make sure that we listen to what the community really has to say. We need to learn from each other. The concept of reciprocity was highlighted, the importance of collaborating, developing feedback loops, the idea of doing community evaluation with community, not for community. And so how do you start with the local learners, like the elders? How do you really focus on creating relationships based on trust that are long-term and that are also sustainable? And then how do we hold each other accountable both ways? And so we had examples from Pakistan, from Ghana, from Canada, and from the US, and we ran out of time. So we said, okay, sometimes we get funded and we have this bright idea. Sometimes, you know, academicians come in to try to do, only to find out that what the community wants and needs is very different than what our idea of important is. So we're reminded that humility, again, is really important. I don't know if I left anything else. Probably did so. No? Okay,
Yeah.
that's it.
Sounds like a rich discussion. Could we have the other community group, Hiba? Can you share some of the discussion point in your group? Hiba, can you hear us?
Hello.
Oh, yes, are you able to report back the main discussion points in your group?
Yes. Can you hear me?
Yes, we can.
evening. So
Hello, Eva. Eva.
You were going to report back from your group.
Yeah, we will do that. Our letter.
Okay, so who is speaking?
Century.
Okay, so if somebody can report back from the second community or first community engagement, Walter.
Yeah.
Yes.
We will do that. We will do that.
Okay, so what are the key points?
Okay, something. Okay, some of the key points is that we exchanged while we were in the session our interest, and most of the participants was that they have seen the issues of racism, discrimination, and they wanted to hear and to learn some strategies about how to do about it. And then some of us share our experience of addressing the issues, and the importance of cultural mediators became very strong in the sharing of experiences, and also experiences in which you do not have to wait for institutions to change from inside. You can also promote and change from working from within the communities, facilitating the empowering community to learn about the laws and the rights, and forcing to open a channel for dialogue and reform within institutions. So we share those kind of experiences, and yes, and that was about.
Excellent. So
Hello?
Lionel, if
no, Dr. No.
He said so.
Can you hear me?
Happy to, I'm happy to report now in quite a bizarre thing. We're in the start of what looked like national student protests across the country. So Tiseto's in charge of his dining room, and the students are about to close his dining room in protest. So
okay,
he literally had to leave to deal with the a student protest matter. So I think I wasn't taking notes for reporting, but I'll go through them very quickly. The issues. I think we spend a lot of time talking about the fact that poor students are not in the class. That there's a great struggle for students to get in, and then there's a great struggle for them to stay because of cash issues. Also because the way their performance is evaluated beforehand is different. And things often depend on where they come from, what religion they are, what gender they are, all of those kinds of things. People spoke about different ways of selecting. There were portfolios, which is essentially being assessed by people who are self-selecting. We spoke about the gender and legacy issues. What I thought was really interesting is that we had in our group a non-health professional who spoke about her desire to be seen by a doctor who would take responsibility for many things. Currently, we're very specialist based. So really the return to, I thought it was the return to primary care in many ways, which I valued greatly. And then I thought what was really important about how we go forward is to embed this in change some of the criteria, I think was the basic thing. But what Ray from the University of New Mexico spoke about was embedding critical race theory in all that we do in a school. And I must say, I found that quite a fascinating consideration. Colleagues, if there anybody from our group, Erica, Mary, Ray, any of you who want to make a comment that I may not have captured appropriately?
Okay. I think I'd also like to add on how we would like to have the admission system also change and be more objective when it comes to admissions of the medical students. But Dr. Lionel Green Thompson has explained what we covered during our discussion.
Excellent. Thank you so much. So the next, what we're gonna do next is we're gonna actually get to the community level, and if I can ask Walter, he's gonna, while I set up his video, if you can maybe introduce to folks what the video is about and a little bit about what you do.
Yes, great. So this short video that we're going to see is from rural indigenous in Guatemala, that the long history of discrimination and racism when they approach public services such as health, that instead of waiting for the institutions to reform, they actually organize themselves to learn about the rights, the law, and also learn about responsibilities. And this is a process that we have been supporting in how they become community defenders of health rights. So that's the background for the video, in which they're going to describe the work that they do. Okay.
Great. So here we go. If all goes well. Nope. Oh, sorry. Wrong. Wrong PowerPoint. Okay. I thought I was.
Los servicios públicos de salud son muy importantes para nosotras y nuestras familias, pero a veces al llegar a los servicios nos encontramos con problemas, no hay medicinas o vacunas o están cerradas. Otras veces nos enfrentamos al personal en los servicios que nos discriminan por ser indígenas, campesinos o mujeres. Y también existen algunos casos en que ante una gravedad médica familiar que necesita traslado a un hospital, las autoridades de salud nos obligan a pagar por combustibles y no nos dan comprobantes. Entonces, nunca sabemos si en verdad se utiliza para eso. Y hay muchas familias que no pueden pagar el dinero que les exigen y que se quedan en sus comunidades sin recibir atención. A través de talleres y capacitaciones hemos aprendido que otros problemas y situaciones violan nuestros derechos, de que no debemos aceptar ser discriminados, que los servicios de salud tienen responsabilidades y obligaciones hacia las comunidades, de que los cobros por servicios públicos es corrupción. Para cambiar la realidad de los servicios públicos, estamos actuando como defensoras y defensores comunitarios por el derecho a la salud. Todas y todos somos voluntarios, electos por nuestras propias comunidades para educar a la población sobre sus derechos y obligaciones en relación a la salud y a lo que le corresponde a los servicios públicos. Recoger evidencia de los problemas que los usuarios enfrentan en los servicios públicos. Defender a los usuarios cuando existe una violación a su derecho, como la falta de transporte, la exigencia de cobros. Dialogar con las autoridades y planes de acción conjunto para resolver los problemas. Apoyar a los servicios locales de salud para que el nivel central los asignen mejores recursos para atender a las comunidades rurales del país. Somos más de 160 defensoras y defensores presentes en 35 municipios del país que pertenecen a los departamentos de Huehuetenango, Quiché, Totonicapán, Sololá y Alta Verapaz. Como defensoras y defensores buscamos continuar con el diálogo y trabajo conjunto con los servicios locales de salud para poder resolver los problemas estructurales que afectan el acceso a los servicios de la población. Nosotros pensamos que si logramos resolver los problemas estructurales, todas las comunidades rurales se van a beneficiar, aun aquellas donde no existen defensoras o defensores comunitarios. Entonces, nuestra meta es nuestro compromiso y trabajo voluntario beneficia a la mayor cantidad de la población posible. También estamos forjando colaboración con otras organizaciones del Estado, como la Procuraduría de Derechos Humanos, para solucionar los problemas y defender nuestros derechos en una forma integral.
Thank you so much for this, Walter, and for this interesting, you know, and important partnership of the change has to happen at every level. I'm gonna pass this on to Eva, who's gonna speak to us a little bit about cultural humility, I understand. So can I pass it on to you, Eva?
Yes, you may. Yes, you may. And I am humble. First of all, I'm honored, and I'm also very happy to be here this morning, afternoon, and evening. The discussion about cultural humility, and you have already referenced to this important set of realities. It's a complicated one. More and more, I see that we are writing about it, and I say we collectively, that the stories and the narratives of what do we mean by being humble are being reflected and are being honored. However, I still see a lot of conversation about, well, it's really about being culturally sensitive. Oh, is it about awareness? No, wait a minute. Is it about competence? No, wait a minute. Is it about all of the above? Or what is it? I would like to take the next 3 minutes or so to really sort of like center on taking cultures to another level, which is the ability to really be humble in what we do. And that is to be intentional at every opportunity we have to acknowledge that what we strive, and ideally what we strive to not only in medical education, but in all types of education, is to be able to understand that no, we're not experts. So just when we thought that we have been formally trained, sometimes we are even privileged to get the degrees. Sometimes we frame them and make wonderful celebrations to the fact that we have all these formal knowledge. The reality is that we don't know. And so humility starts with the premise that it is okay to be silent. It is okay to ask new questions, not the same questions. It is much more important for you to be present and really understand the power of being mindful about the opportunity that you have to engage with the other. The reality that it takes a lot of learning to get to the point of being humble, and that we don't need to try to fix everything that we see or that we think it is broken. And that in itself is a really difficult thing to do. I must confess, you know, my training is in social work. So what do you think social workers love to do? We claim that we love to help people, right? We're good at that. And even if we don't see problems, we come up with problems because we want to do the offerings. Well, I've been learning in life, and it took me a lot of years to realize that no, not everyone needs your help, Eva. As a matter of fact, no one asked for it. And so therefore, it is really important, to try to remain humble and genuine in your approach. Humility is about being curious. Yes, extremely curious, but also understanding that you are vulnerable. And I don't know about you, but I have felt the most empowered when I realize that I am very vulnerable as a human being. And in doing so, that I take responsibility for understanding that I don't have the answers, but I'm open and I'm willing to learn from the other. And when I do that, I have found myself just being a little bit more, I don't want to say even effective, but much more mindful and understanding about how to engage with others. So humility is about being humble and also challenging the fact that no, you're not always skilled to work with the other individual that comes from a different set of cultures. And it's really the commitment that you are always on the reflection mode. I don't know how many of you have read the work of the late Paulo Freire about concientización or raising consciousness and how important it is to be able to name the world that you see. Because once you begin to name the world, you begin to own, you begin to really say, this is called discrimination. Wait a minute, this is bias. Wait a minute, this is an injustice. Wait a minute, this is harassment. And so therefore, by beginning to name the world, the power of the literacy begins to really give you the self-confidence and the efficacy to then act on that is the world. That is, I think, at the heart of the cultural humility task that we have in front of us. So humility is about creating relationships, in this case, with your learners, with your peers, with the communities that you serve. It is an opportunity for you to really practice being listened to and listen to others. Again, I think I said this and I want to underscore it, realize that no, we do not know it all. And sometimes in our trying to help, we undermine what the other individual is bringing to the conversation. It's so good to not know. It's almost liberating not knowing, because then it allows me the opportunity to really learn from the other. I said that it takes self-reflection. It's being self-critical. It's not only addressing what is happening, but readdressing. It's always stepping back and asking yourself, what is it that I am listening? And what is the story behind? And what is the lesson? There are three take-home messages that I want you to be just sort of like consider. Cultural humility is multidimensional. How I wish that sort of we could go into a training, take 2, 3, 4 semesters, walk away with a certificate that would claim that we're humble in what we do. There's no such a thing. However, there's a wonderful body of literature. If you're interested in the subject, check out the work of Dr. Vivian. Vivian Chavez. Dr. Chavez has done incredible work with peers around cultural humility, especially in medical education. So it's multidimensional. So there are 3 take-home messages that I want you to consider. Cultural humility, it's a lifelong learning, which means that just when you think that you're humble enough to understand the other, you need to pause and realize that no, you don't get it, because there's actually more learning involved in your ability to relate with the other. So lifelong learning, it's a development of the critical self-reflection. And remember, because we're complicated human beings, we all have important stories to share. So what we are called, how we were referenced, what histories we bring, how I get to say who I am and not the other define me, all are critical elements of what cultural humility is. The second, I think, key message is that with cultural humility, we can begin to identify where are the power imbalances between the haves and the have-nots. I think Anita and several of you talk about these dichotomies of who has and who doesn't. In the area of medicine or in the area of health and human services, we see and hear the clinician that traditionally has the power, has the agency, has the knowledge, and we have the patient, the client, who passively acts on a relationship or an encounter or a transaction. Humility says we're equals, and I'm here to learn with you and from you. And I start where you are and I build on what you know. The third key element of cultural humility is that we need to use it to really hold ourselves accountable. And that is individuals as well as the institutions and the systems that we're affiliating with. So let's see. So I think in closing, I want to reiterate a few things. So listen to the stories. No, we don't have all the story. Engage in personal reflection. Become a co-learner of what you're passionate about. Be present. Choose to see and observe. Really strive to develop relationships and partnerships. Don't assume you have all the answers, even though you may have the knowledge. Be relaxed. Look at the body language and allow for the process to flow. And so I don't know if I have any more time. And if I do I have any more time, Vijar, or am I done?
If you have a key point, that would be great. I also know later if you can share the reference of Dr. Chavez in the chat later on. But yeah,
Absolutely. So in closing, we have, I think, a task in front of us, which is fantastic. I think we're in a group of colleagues and friends that really value critical thinking. I heard you say critical race theory as a backbone to how we look at the world. But we need to figure out a way to embed social justice in the work of what we do. It has to be intentional, especially in the way that we educate and form our future workforce. And in doing so, we really need to be critical consciousness advocates. And critical consciousness means that we name, we act on what needs to be acted upon, and we take responsibility for. We also need to be patient with each other because this takes a life of its own. We need to be willing to take risk. We need to have a commitment to authenticity, and we need to let go of perfection, which gets in the way really of being able to be authentic and human. And so with this, I would like to pause and maybe we would have additional time to have conversations.
Absolutely. So I just want to, so what's happening next is that we're going to actually have this, a little bit of interaction. So just before that, one of the things that Dr. Willeta Lema was supposed to have a recording, but didn't have time for that. So I want to start asking her a question. She has been working in all levels of the health system, both in health workforce education, both in Ethiopia and the United States. But I wanted to sort of get your reflection on particularly the area you've been working on lately in terms of the digital divide in the area of COVID. How do we ensure that ICT for development efforts, and I guess we haven't really talked much in terms of global health as well, how can we ensure that ICT for development efforts aren't discriminatory, biased, or sort of more colonialist in nature? So I'd love to hear your perspective on that, Willeta.
Thank you, Bjorg, and thank you, participants. Can you see my slide?
Mm-hmm.
Yes.
Yeah. As Bjorg said, I've been, I should say, honored to work on both sides of the North and the South for the last 20-something years, working in universities in the US for many years, and then now also working in Africa. So the topic we are talking about is health equity, racism, and divide, North-South within the university, things like that. What I want to focus is something that we need to consider in the world, in health education and medicine and things like that. The world is becoming digitized, whether we live in Washington, DC, or Addis Ababa, or South Africa, or Guatemala, wherever. But I don't believe that the digitization is going as fast as it should be, or is inclusive enough for all the learners out there. And COVID actually has made it very bad. So this is a very striking map that you can see. I hope you can see this is the digital divide. In most of the schools that we are talking about, medical schools and others in many parts of the world, the light up is where there is broadband connectivity, things like that. But look at the continent of Africa, hardly much connectivity. And we are talking in 2021 about internet connectivity, e-education, virtual education. We are even meeting in Europe, and some of my colleagues are in Africa or in Latin America and things like that. But this is not getting to our students and to our medical professionals in Africa. So I want to talk about two things. One, the digital divide in education. The other one, the solutions that are coming to Africa, like you are asking me, that are not well thought of to meet the needs of our population, in this case, in health, digital IT, digital health, information technology, and things like that. This is the reality that we have today. COVID has brought the world together, but it has also showed us that there are billions of learners, not only in Africa, but all over the world, even in the US and Canada, where people, not only young people in junior high and high school, but in universities. When COVID came, most universities closed, and the students were told to go back to their villages or wherever they came from, interrupting their medical and other education. For me, this is health equity. Health equity, we have to look at it in a different way, looking at it as a digital divide. If the world is connected, and if our doctors and nurses and others trained are not being able to access the rich information that we have nowadays, then I believe that is also discrimination in some ways. This is where Africa is. If you can see, even if you have a mobile, Africa is the fastest continent where you have mobile penetration, is still very expensive. Very expensive for the normal population, but very expensive for our students also, for our medical students, nursing students, where you are supposed to get your information. I also want to challenge us to think, if we don't train our medical doctors, nurses, and others to this fourth, it's called the fourth industrial revolution, in all our schools, north and south, when they come out, what they are going to face is a digital world. A digital world where AI and others may replace some of the jobs that we are training them. When they get out, they don't get jobs to do that. I also want to talk about most of the solutions. So I want to talk about health equity in terms of education, health education, medical education, but also solutions. You'll be surprised how big the African market is. This is the African healthcare market, huge, anticipated. But part of this, or a percentage of this, is not being used to help digitize that picture I showed you, so that the students, the health workers, can benefit. And even if it is used by people where the solutions are made in the north and the solution in the south are not incorporated, or the people solution, what the mothers need, what the healthcare worker need, is not incorporated. Why? Because the solutions we build also, for me, are not sensitive, culturally sensitive. Sometimes I feel we need nowadays in our medical schools, but also in implementation to narrow the healthcare divide, anthropologists with us. I really do believe people who understand cultures, so that the solutions, the education that we built is very much sensitive to the local population that we are serving. So with this teaser, I will be very happy to answer any questions and follow up.
Thanks, Muleta. So let's just open it. So you've heard from a lot of folks, and I think, you know, and we know there's, again, a lot of wisdom in the room. So if you have specific questions, comments, I mean, the theme, we do want to move towards what's working as well. And we hope that there will be some follow-up and some activities that could be done together. But I want to open the floor if people have questions or comments regarding any of what they've heard today. So please feel free, just unmute your mic and pose the question. If you if you have technical issues or otherwise prefer, you could also do it in the chat. Any questions either for Violeta or Eva first, and or comments also?
So it's an interesting divide. It's Sarita here, Violeta. You know, in terms of the digital divide, I think that's fascinating because much of what we're talking about here because of COVID is moving to virtual medicine that relies on a huge amount of technology. But in the North here, in fact, on First Nations reserves, there's very little Wi-Fi or internet connection. So I find it interesting that people are talking about virtual critical care and, you know, individualized medicine where you can talk to your doctor on the internet. But in fact, we have this other world here that doesn't have that connectivity. And that's very much what you're saying about the rest of the world. So wouldn't it be great to have a market where we created that kind of technology and made it available on open access? And, you know, is anyone even talking about that?
No.
Dr. Lema, this is Ramonde. I just thank you very much for the talk. I just also wanted to say that I spent some time on this topic, trying to look at global burden of diseases in adolescence and how there were, if there were any digital health projects that were targeting adolescents in low and middle income countries. And I found practically nothing apart from a few for sexual and reproductive health. And that's apart from the divide. So I'm in Cape Town, which is, you know, urban and quite affluent. But as a TB physician, I definitely see what the impact of not having access, both to health in rural areas as well as to infrastructure and technology in rural areas, is having on migrations of populations. I mean, when we look at our TB sort of genotyping, it's amazing when you can track where these infections are coming from. They're actually coming from places where people have no health access, and they're moving for health access and continuity of care. And that in itself has a knock-on effect in terms of health infrastructure and, you know, everything else, water, electricity, sanitation. And it just seems like we're in this crazy merry-go-round of, unless we actually equitably address the issue, even in rural areas, in a sustainable way, and for older populations meaningfully, that it's just a runaway problem. So sorry, that's more of a pessimistic comment than anything else.
Björk here, I just wanted to highlight, I think it is really important issue. It's also, and I think this happens no matter what, but who creates the technology, who creates the algorithms, you know, unless we fully, you know, reflect different perspectives, that's going to color both who has the power and who has the resources to access and design. And often I think in development aid, there is a tendency to have tools developed by, you know, well-meaning NGOs or for-profit companies in higher income countries, whereas the local knowledge is what, you know, is more likely to produce what's needed. So I thought that was a really important point that you made, Violeta.
Yes, thank you.
Discussion here, I saw that Sinkiri was talking about, so what are policymakers doing about this inequality? Any thoughts on that? I think people are sharing. That's really great, because we do want to keep a positive focus on, you know, what is working as well. But any thoughts, any other comments or questions to anybody else? Eva or Lionel, Walter, and Toya Shea unfortunately had to leave, but you know, obviously Sarita is here as well, and Anita and Hiba and all the folks that have been talking. So feel free to ask questions, make comments, point what you think is the most important thing that we can or should be focusing on.
You know, this is Eva. There's a part of me that says with the digital divide, it's clear that we have to figure out a way to build health literacy and use technology to our advantage. And so the question is, how do we do that? And where do we find the technology and the infrastructure in place? I'll just give you an example that worries me. If it isn't for the limited technology that, for example, brothers and sisters that are coming in as new immigrants, primarily referred to as immigrants, refugee, asylum applicants. And I try to stay away from those terms because each of those terms is loaded. If it isn't for a cell phone and the ability for them to connect with loved ones, they're totally disconnected from the world. So I'm sitting here saying, how do we use the technology that we have and ensure that we are advocating for the adequate use, the accessible cost, the equipment that is necessary, you know, at the community level? And how do we make the most of that to promote literacy, to do health, but to also engage our medical learners in helping us to translate that into health? Does that make sense? So yes, we're going to stick around with telehealth without a doubt in the United States. I see telehealth making more and more presence. I see telemental health becoming also an alternative. I see social workers now more engaged in telecommunications. But what about the elder that doesn't have the access or maybe wishes not to engage in a telehealth or in a digital experience? Well, what about the immigrant, migrant, or the other that it has literacy realities that don't necessarily fit with the schemes or the systems that we have? I'm making just a reference of the United States, but it may be in other countries we're also seeing those challenges. So I don't have the answers, but that certainly worries me. And we need help in trying to figure and advocate for the adequate funding to make sure that we make that happen.
Thank you, Eva. Any thoughts, comments, burning issues, or are people, I know this is a long, long session. So, yep, go ahead.
Sarita, I think going forward, I think I need to work in my own mind around the distinction between issues that are about racism that actually compel us all to be strong advocates. If you see it, speak up. If you hear it, speak up. I mean, advocacy is so important, and having the courage to feel safe to say things that we heard actually from our student panel, which I think is inspiring. But the distinction between that and the impact of racism on health inequity is like, it's a different conversation. Although they're interrelated, the impact on health inequity is really a political and institutional issue. And what we have to do is basically make it an election issue. Certainly here, you know, and in Canada, and to get the government, which funds healthcare, to understand that this is just no longer acceptable. Like the healthcare in some parts of Northern Canada is just tragic, you know, no water security, no food security, personal invasion, and impact on violence. So I think that I'm just trying to work in my own mind the role of the medical school, definitely in curriculum, admissions, policies in the medical school. But the big picture is to become an activist.
If I can say something, I think I like the idea of the open access. I think the second part of the discussion, which is the impact of racism on the health equity, is a very important issue, whether it is the population in Europe or in America, or whether it's in Africa or Asia. I think we need to work together to make sure that the health inequalities don't become bigger and bigger because of the digitalization that is happening around the world. I also believe that there is also another issue we haven't been talking about, North-South privacy. Digitization is now bringing to the issue of our privacy, our private information. Mobile, the population, whether they are poor or not, if you study mobile penetration in many countries. Even the poor will use their monthly salary to buy a mobile. And now in COVID, we have seen that there are many things, many apps, many things that are looking at, taking information in many countries. So our populations are not also ready for that part. So I believe the impact of racism on health equity is very important. Maybe it needs its own discussion. And some of these big schools that are working and training medical doctors and public health experts, I think need to be in the conversation. It shouldn't be the tech companies which alone driving the conversation. I think the educators have to be in it and be activists so that the digital divide can be narrowed.
So one of the issues that we've, was in the title and the topics we're covering is broad and complex. But any thoughts or comments on and perhaps also from countries that are often more recipients of development fundings is sort of, what about racism and bias in global health? What can education institutions, for example, in Europe or the States, what are they doing that, well-meaning or not, might actually be fueling inequities one way or the other, or at least at best, perhaps not necessarily addressing sort of the capacities of, I know capacities of local institutions. I know that from the work we've been doing with health workforce education institutions, with some exception, but a lot of the development funding tends to go to a university in a high income country. What is the message that, or you have consultants that are coming in or just graduates out of school and they are coming in advising governments? What are the messages and that we're sending in that way as well? So any thoughts of about global health issues that we need to keep in mind? Look, if I guess for it's been a long session on an important topic. So unless there are some comments or particular questions that you have or that you want to address, we can also just we're hoping that this will actually just be the beginning of collaborating. We know probably a lot of you are working or at least have interest in this space, and I think there's a lot of clutter out there in terms of what's happening and a lot of priorities. And certainly we're hearing that with COVID, a lot of resources, human and otherwise, have been drained. So it's important, I think, for us to try to figure out how do we keep this issue, away from being nice to do, but have to do. I think COVID has certainly demonstrated how essential health equity is and how essential it is to address the underlying structural racism and discrimination and gender inequities that are still there. So, we've heard a broad range of issues, the importance of listening to, being humble and working with communities and partnering with, and really having it not just a token way of getting people on board, but actually truly having those communities we want to serve as the driving force and part owning, what has to happen. So any comments or key question? Otherwise, I will just try to sort of move towards closing down.
Hi, this is Emilia Iwu. Hello, Beard.
Hi, Emilia.
Hi, we meet here too. So I just thank you for bringing up global health, and some of us who are global health practitioners living through this experience, both in the developed and up and coming countries together, we are in a very advantageous position to really create an awareness of, being conscious and being intentional when we travel to other countries to not perpetrate some of the biases that we are talking about here. So thank you for bringing that up, because oftentimes we come from an advantaged position and we may silently not even realize that we are also creating lack of inclusion if we are not very careful when we go abroad to practice. It is very interesting that COVID-19 pandemic has grounded us right now, and some of the social issues that we are talking about today have brought to limelight the issues about diversity, inclusion, and how excluded we have been all along. So as we practice in the global arena, it is very, very important that we take these awareness, conscious awareness now with us, and make sure that we are being inclusive in the countries of practice, that we are also open-minded and listening to those people who are on ground, because we are not actually the experts. Over the years, we have learned that we are learning from them more than they are learning from us, you know. So thank you for bringing that up. And I just want to say to our colleagues that are here today to really be mindful of some of our language and body language, be spoken about body languages, or how we actually implement services to make sure that this conscious awareness that we're living through right now, that we take it with us and be able to implement it as we travel the world. Thank you.
Thank you, Emilia. That was really important. And then I see there's a point in the chat in terms of research, how, who does it? And I've certainly seen illustration, I'm sure many of you have too, where you look at where the knowledge about in peer-reviewed publications, where that comes. It's usually in the US or in Europe. So the perspectives of what we are supposed to know is actually not coming from the source itself. It is our interpretations. And
yes.
So I think it's really important to think about that and think about who you're even writing it for or doing that. I think we need to really be conscious about that, because, maybe well-intended, but we could be totally distorting perspectives. Apart from being, neo-colonial or.
Right. Thank you. I think in the aspect of research, making sure that each time that we are doing research in our countries of practice, to make sure that we are trying as much as possible to include the owners of that data, to make sure that their voices are coming out and they are vetting our conclusions from the data, to make sure that in publications, in presentations, even when oftentimes the funding is not available for them to attend conferences where we are sharing that information, that we include them and their voices in our presentation or the work that we are sharing. So we need to be intentional in terms of including them on purpose. You have to include them. Make sure that when the data, even if it's statistical data that is speaking to you is blatant, make sure that you share that with them and say, this is what this data is saying. Is it okay if we conclude it this way? And then if there's a caveat to that conclusion, to make sure that we are also sharing that, because what the numbers are saying may not be what they are feeling. So thank you for pointing this out. I know we can talk to tomorrow about global health practice, but I'm going to stop there for now. Thank you.
Thank you so much. There's some great, please read the chat. There's some great ideas. We will try to capture this. And the idea is to build some sort of monograph or beginning of a collaboration, have some sort of written document coming out of this. So we see this very much as a beginning. We know there's a lot of groups out there that are fighting for social justice and have for decades. But I think that what is sad, especially with the current situation, is that we end up competing for funds and attention spans. So if we can find ways of sort of building on each other's strength, using each other's resources and find ways to actually build a sort of tipping point and keep this topic along, because that's my big worries and with COVID, is that it has it's taken up so much air, it's taken up so many resources that there's a danger that this incredibly important issue, which clearly keeps, isn't truly being addressed all around the world. I don't think, we've seen maybe more about it in the States, but this is truly a global issue. Now, as Lionel was saying, I mean, it takes many forms. Poverty is another perhaps issue that then builds this discrimination. So if you're interested in continue this discussion, I did put in I can show you an email here. So if you want to participate, we are going to try to build a set of resources as well, so that we can start the sharing and think about developing, some sort of document. Sarita, is there something you want to add to this? Otherwise, I will just share the email which I put into the chat. If everybody can see that, I can.
Well, I just want to thank everybody, our group of people who worked together, who came together through bizarre meetings at all hours of the day to be able to pull this together. I want to thank you, Bjorg, for your leadership, and everybody who contributed to really a wonderful conversation. I'm a person who believes in pragmatic outcomes, and I never like to leave a place without saying, okay, here's what we're going to do. So I think that we should get people to send us any ideas that they have that would go into the best practices and the action plan for a monograph that we should create around health equity and anti-racism, and we should really get that out there, internationally accepted. I like the idea of a journal that Colleen had sent, so we should think about that and how we could solicit international input into a journal. And then finally, I would like to see a student group continue on with this conversation. So I'm going to think about how we can collectively support students. They're the future and they are the leaders of today. So I would love to be able to talk to Pantangeli and Anita and all these students that contributed, Hiba, about how we can do that. So thank you, Bjorg. Everybody, thank you for your time. Well done.
Thank you so much. And thanks to all the students here. So in terms of the issue of students, the Network Towards Unity for Health, that's actually where some of the students and faculty came from. So that is one way, but I know there's different organizations, and I know Anita founded one. So let's continue the conversation. Thank you so much. Let's go fight for social justice. See you next time around.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks, Bjorg. I think it went well. We'll do a debrief, maybe, if you want to set up a conversation for us.
Definitely, we should set up a meeting afterwards and sort of concretize that and pull together all the notes, so we can see, where do we go from here.
I'm going to run off. Thank you. Thank you, everybody. Lovely working with you all. Nice to make new friends.
Be well. Stay healthy.
Be well. Stay healthy. That's right.
Yes.
Stay safe. Bye.